a radial artery access and sheath introduction. The problem. Common cause of failed transradial catheterization is unsuccessful radial artery access. First time attempt matters. First attempt has the highest chance of success. An injured artery may spasm, making subsequent attempts more difficult. Proceed slowly and carefully, especially when first learning. Reducing local vasospasm. General sedation with mild analgesia with adequate but limited local anesthesia. The ideal puncture site is 1 to 2 cm proximal to the radial styloid, the bony prominence of the distal radius. Sites near the radial styloid risk puncture of the radial artery after its bifurcation and may make threading the guide wire difficult through a stretched and flattened radial artery. Extremely proximal punctures are more difficult to compress and can result in hematoma formation. So while giving local anesthesia, a small amount, that is no more than 1 milliliter of local anesthetic, injected subcutaneously, raising a small wheal similar to a tuberculosis skin test. Larger amounts of anesthetic can obscure the pulse. A through and through technique. The course of radial artery is fixed with the index and middle fingers of the non-dominant hand. Using the other hand, the micro-puncture catheter over needle system is inserted with the bevel facing up at 30 to 45 degree angle to the skin along the direction of the radial artery until a flashback of blood is visualized. The system is advanced until the back wall of the vessel is punctured and blood flow stops. Through and through technique is shown. First there is insertion, then there is a little withdrawal. If no flashback of blood is observed, this can occur despite intraarterial puncture. Advance to complete the back wall puncture. In this situation, the needle is then removed and the catheter is withdrawn until its tip is intraluminal as confirmed by freely flowing blood. 0.018 or 0.025 inch straight tip or slightly angulated guide wire is gently inserted using a twirling motion. There should be no or little resistance to wire introduction. If the resistance is encountered, fluoroscopy should be used to immediately visualize the position of the wire. Once the wire is securely and freely in the vessel, the cannula is removed over the wire. Here in the picture, it is shown how to puncture the radial artery and insert the catheter. Single anterior wall puncture of the radial artery using a bare metal needle. With initial flashback of blood, the needle is advanced a millimeter further to ensure that the whole tip and not just the tip of the bevel is intraluminal. If blood continues to flow freely, the needle is fixed and a 0.025 inch straight tip wire is advanced into the artery. The needle is then removed. Note that only metal guide wires should be used with bare metal needles, as plastic coated wires used in this scenario can be shredded if they are pulled back against the bevel. Radial artery sheaths have a tapered tissue dilator and vary in French size and length from 10 to 36 cm long. The combined use of a graduated dilator system and hydrophilic coated sheath typically obviates the need for a skin nick prior to the sheath insertion. However, some operators prefer to make a small incision over the wire in preparation for sheath introduction. This is Merit Medical 4 to 7 French size. This is Cordis Radial sheath. This is Glide hydrophilic radial sheath. This is Nora radial sheath. This is X-Way made in China. Umbra medical radial sheath visible in this figure. Hydrophilic coated sheaths will reduce the spasm of artery and pain of radial artery upon sheath withdrawal. They also reduce post-procedural inflammatory reactions. Long sheaths are for tall people, for patient comfort and better catheter manipulation, but their effects on long-term patency of radial artery is unknown. Sheath and wire. After loading the sheath onto the wire, the sheath is held close to the distal tip to avoid bending of the equipment. Steady but firm pressure is applied until the dilator has advanced into the artery. The same steady pressure is used to advance the sheath past the dilator sheath transition point into the artery. If there is resistance, use wet gauze to make the hydrophilic sheath slicker, and gentle rotation during advancement also facilitates sheath insertion. Alternatively, the wire can be removed with the sheath halfway in and then reinserted after administration of a vasodilator cocktail through the dilator. Once the sheath is fully advanced to the hub, the dilator and guide wire are removed together and the sheath is flushed. A large tegaderm placed over the head of the sheath can secure the system without the need for suture. A nick in the tegaderm at the opening of sheath diaphragm allows ready access for catheters and guide wires. Medications are crucial because radial artery is very vasoactive. Flow around the sheath at the site of radial axis is sluggish, which will increase thrombus formation. Anxious people and those with high sympathetic tone are likely to have vasospasm, so the use of local anesthetic, sedation, and analgesia are important. Once access is achieved, intraarterial injection of a spasmolytic agent such as nitroglycerin, verapamil, diltiazem, adenosine, or papaverine is essential for minimizing vasospasm and discomfort. Calcium channel blockers may be longer lasting than nitrates, although they are also associated with intense burning sensation and should be diluted to mitigate discomfort. Spasmolytics can be repeated as necessary throughout the procedure during catheter exchange if the hemodynamics allow. For anticoagulation, weight adjusted unfractionated heparin 40 to 70 units per kg up to 5,000 units is administered to prevent thromboembolic complications and radial artery occlusion. This can be given immediately after insertion of the radial artery sheath. Some operators prefer to wait until successful passage of a guide wire into the ascending aorta has been achieved in case of need to convert to the femoral approach. Administration of unfractionated heparin IV is preferable as it causes less discomfort than intraarterial injection. Medical regimen for radial cath before procedure: topical anesthetic over the radial artery, optional. Sedation 0.5 to 1 mg, Versed and 50 microgram fentanyl, typically given together, but one or the other may be used in elderly or in patients with respiratory compromise. Local anesthetic 1% lidocaine, Use no more than 0.5 to 1 ml of lidocaine. After sheath insertion and before catheter insertion, intraarterial spasmolytic like nitroglycerin 100 to 200 microgram for most patients. Verapamil 2.5 milligram diluted into 10 ml of blood or saline. IV unfractionated heparin 40 units per kg bolus up to a maximum of 5000 units. After procedure and before sheath removal, verapamil 1 to 2.5 milligram is an optional medical treatment.